milligrams, having basically a placebo-like reduction in the brief psychiatric rating scale score or the positive and negative syndrome score, although the side effects were rather similar to the full dose 1.5 to 6 milligram arm. And then on the far right you see two arms with quetiapine 600 or 800 milligrams, again showing significant efficacy. The only study that has not been published yet is the ziprasidone trial that was recently stopped. There has been an active control trial that was NIMH funded, the TEOS study, recently published, the treatment of early onset schizophrenia spectrum disorders, where patients were randomly assigned to either molindone, the first generation antipsychotic, doses between 10 and 140 milligrams with a mean dose of 60, or olanzapine, 2.5 to 20 milligrams with a mean dose of 11.4, or risperidone, 0.5 to 6 milligrams with a mean dose of 2.8. And what you can see here in the unshaded bars is the response where patients had at least a 20% reduction on the PANSS score and a CGI, the Clinical Global Impression Scale, of much or very much improved, and that needed to be basically sustained. Our patients needed to complete the 8-week study. That's the solid bar. And then the shaded bars are the ones that needed to be completed, the study, which was an 8-week study, which is the stricter response rate. Although the study was somewhat underpowered to show differences statistically, you can see that numerically, basically, there was no difference between the two atypical antipsychotics or molindone as the typical antipsychotic. NIMH, the Data Safety Monitoring Board, had to stop the study arm for olanzapine prematurely because it was clear that there was no advantage in terms of efficacy, but there were much more evident cardiometabolic side effects with olanzapine, which made it unadvisable to expose more patients to olanzapine. However, the patients that had been randomized to olanzapine could be completed in the study, or could be continued and complete the study. This is a rather busy slide now, looking at response rates, but I wanted to provide an overview of the response. The number needed to treat here is between 5 and 10, which is somewhat higher, meaning not as favorable as we've seen it for aggression with autism or disruptive behavior disorders, or even in bipolar disorder. There is a variability in terms of definition of response, which may explain some of the variation compared to placebo. In the middle you can also see the response rates that I just explained in terms of the TEOS study. But on the far right there are two studies that compared clozapine either against high-dose olanzapine, that's the second study to the right by Sanjeev Kumra, and basically here the number needed to treat was just 3 in order to get patients better, one more responder compared to olanzapine. So the clozapine studies have a lower number needed to treat, and on the far right is a smaller scale study comparing clozapine against usual dose olanzapine. So the efficacy of antipsychotics, particularly atypical antipsychotics, has been established now very well in the last several years in pediatric schizophrenia, bipolar disorder, disruptive behavior disorders, as well as autistic disorders in terms of aggression and irritability. The question then is, what's the other side of the coin of effectiveness? What's the side effect burden, and how different are medications? And what we can say in general is that, like in adults, efficacy differences, except for clozapine, which is more superior in refractory patients with schizophrenia, seem to be rather small, at group levels at least, and hard to predict. On the other hand, differences in side effects are rather large and easier to predict, with each of the medications having a unique profile that differentiates it from the other agent. And we will go through that in the next section. But what we can also see on this slide is a summary of the comparison of side effects in children and adolescents versus adults. And what has become apparent is that children and adolescents seem to be more vulnerable to certain side effects that occur more acutely. Those include sedation, Extrapyramidal side effects, particularly Parkinsonism as well as dystonia, but not akathisia, and withdrawal dyskinesia seems to be higher. Prolactin-related side effects, or at least hyperprolactinemia, is higher in children than in adults. Weight gain and dyslipidemia seems to be higher, although it's still unclear to what degree this is more due to the lower exposure rates of children and adolescents to prior weight gain because of shorter exposure to antipsychotics compared to adults, or whether it's an inherent biological mechanism that growing individuals have a stronger effect of antipsychotics on growth-related things like weight gain and lipid abnormalities. And then suicidal ideas and behaviors, as we've seen with the antidepressant literature and maybe even mood stabilizers, may also contain a signal that is higher in children and adolescents. Conversely, there seems to be a lower rate, and most of us believe it's maybe just a delayed rate that we don't see in these shorter term trials in kids, concerning persistent tardive dyskinesia and diabetes mellitus as well as metabolic syndrome, those events that take longer time to actually develop. So let's go through these side effects step by step. Extrapyramidal side effects are more likely to occur in youngsters and in the elderly, as you can see in this study by Keepers et al. Same is true for dystonia, which is higher in younger individuals, but akathisia does not seem to follow the same pattern. It's actually higher in the middle-aged population, suggesting again that maybe akathisia is not so much predominantly a dopamine-related phenomenon, but maybe more noradrenaline or serotonin-related, which is also why we treat it not with an anticholinergic, but rather with a benzodiazepine or with a beta blocker. Let's look at the neuromotor changes in the TEOS trial that I alluded to before. Lynn Sikic published this last year, and you can see here that basically the benztropine use, which had been given preemptively, prophylactically in a double-blind fashion to molindone already at 0.5 milligrams BID, was during the trial still higher than with risperidone or olanzapine. So 42% of patients required on molindone required additional use of benztropine on the far left, molindone in red, risperidone in green, and olanzapine had the lowest need for additional benztropine use, which makes sense because even at low doses the blockade of cholinergic and histaminergic receptors is the largest with olanzapine compared to the other two medications. Propranolol use was somewhat similar, but there was a significantly higher rate of akathisia with molindone compared to the other agents. There was no real difference in terms of Simpson-Angus score levels, although, as you can see, patients were also treated with benztropine, which may have watered down the effect. And in terms of akathisia ratings, the Barnes akathisia scale score also showed that there were more mild akathisia rates with molindone. On the AIMS, the abnormal involuntary movement scale, there was no difference. Looking now at the akathisia rates in the placebo-controlled randomized trials, you can see that at least on the far left, at least with the dosing schedule, the titration that was used in the aripiprazole arms in schizophrenia, the 10 milligram arm did not separate from placebo. Both had a 5% akathisia rate, but patients were started on 2 milligrams for 2 days, 5 milligrams for another 2 days, and then on day 5 they reached 10 milligrams. And then it was stepped up again every 2 days by another, then to 10, from 10 to 15 milligrams, then to 20, 25, and 30 by day 13 for bipolar disorder and day 11 for schizophrenia. But on the higher dose, there was a higher rate of 11.8%. But even with risperidone, which is the second study, you can see that particularly at the higher dose, 3 to 6 milligrams, there was also a signal of about 10% of patients having akathisia. Looking at olanzapine, very low rate of akathisia, about 1%, and even with ziprasidone, about 5% against 1.1%. And on the far right, you see a bipolar disorder study with aripiprazole, where there seems to be a higher rate of akathisia even on the lower dose. Most of the akathisia in these trials was actually time limited and mild or moderate and not severe. The big concern with typical antipsychotics in the neuromotor realm was not only